Everyone, and welcome to today's presentation, which is the Beers Criterion Medication Use in Older Adults. It's a presentation on a science-based list of medications that are potentially inappropriate for use in older adults. Thank you so much for joining us today. My name is Sarah Chimbanga. I'm the Community Health Director here at the Lakeshore. I will be your co-host today along with our Community Relations Director, Jane Rongren. A little bit about myself and my position here at the Lakeshore. I manage and oversee the health and wellness programs here at the Lakeshore, one of which is our assisted living program. We also have a pretty robust wellness center that is staffed with an amazing team of licensed nurses, as well as nursing assistants who are available 24/7. If you ever have any questions about the wellness programs that we have, the providers that we have here at the Lakeshore, the services that we provide for both assisted living residents and independent living residents, please feel free to connect with me at any time. I'd also like to talk a little bit about our collaboration with the amazing University of Washington School of Pharmacy. We are able with this partnership to provide additional services such as medication review for all of our residents. If you ever have questions about medications, we're able to reach out to our pharmacists to help review them with you. We also are able to put on presentations similar to the one that we're having right now. In this online presentation, Dr. Abby Winter will discuss Beers criteria and how to talk with your prescriber about medications that may be potentially concerning. You will also learn steps to take with regards to medications to help keep you safe. However, before we begin the presentation, I'm going to hand off to my co-host Jane to go over a few housekeeping items just to make sure that this is a positive experience for everyone. Thank you.
Awesome. Thank you so much, Sarah, for being our introduction expert today and joining us. Really appreciate that. All right. Hello, everybody. First, we want to make sure that we go over a few things, like Sarah said, to make sure everything is going all right. First thing we need you to know is that unfortunately, we are unable to troubleshoot any of your connection issues or your Zoom controls during the webinar. So you will want to adjust your settings before we get started with our great presenter. All of our participants, you are currently muted from our side of things, and we ask that you leave your computer or phone on mute during the presentation. There will be times throughout the presentation that Abby will stop and ask questions, and you are more than welcome, and please do unmute yourself, and we can try and help with that, so that if you have any questions to ask, you can be heard. For those of you using video, we do recommend that you put your Zoom screen in speaker mode. And as you can see on the slide that is showing right now, that I'm currently sharing, this means that the only video that appears on the Zoom screen is the person speaking, or the shared screen that we will give you, like is happening right now. To turn on speaker view, you want to move the mouse on your Zoom screen and click on the speaker view button in the top right corner of the Zoom screen. If the button says gallery view, that means you're already in speaker view. So you're good to go and you don't need to make any changes at all. For those of you who have joined by phone, you get to just relax and listen. And again, if you have any questions when we take a time for that, you'll be able to ask your questions as well. Today, throughout the presentation, our speaker will periodically offer the opportunity to ask your questions. If you have joined us by phone, you can email your questions to us after the presentation, and we'll respond within the next day or two. You've got an email address from the invite that was sent out that you can reply to, or you can go ahead and use this community relations email address that you see on the screen. LKS stands for Lakeshore, and to get the whole department, you'll just type LKS_communityrelations@eraliving.com. All right, if you have joined us by video, you may ask questions also by the chat feature. To access the chat, you just move your mouse over on the Zoom screen, and you see that the black bar appears at the bottom of the screen. The chat button is there, the second one from second icon from the right. You'll just click on that and you can start typing a question to the group. one last housekeeping. Oh, sorry, I missed this one. You probably all know how to start your video or not. Same area as the mute and video button. You can click on that button if you want to show us your faces, smiling, shiny faces, and join us for the event as well. So, Dr. Abby Winter, I am delighted to welcome Abby to us today. With us today, she's joined us to present on a very, very interesting topic: medications that are potentially dangerous to older adults. It is brought to you by the Lakeshore. Abby is a licensed pharmacist and clinical assistant professor at the University of Washington School of Pharmacy, and she serves as the director of outreach for the Plain Center for Geriatrics. She also leads the educational, clinical, and outreach efforts for the UW School of Pharmacy at all 8 of our Era Living communities, and we are excited to have her here with us today. So I am going to turn this over to Abby and let her share her screen, and we'll get started, and I will talk with you at the end of the presentation. Thanks again for joining us, and we'll see you at the end. Here you go, Abby.
Thank you very much. Give me a moment here just to share my screen. I practiced a few times, so I think we should be good to go, but you always know with new technology, there are often some concerns. So give me just a moment here. And I think we are good to go. Great. All right. Thank you everyone for joining today. As we said, my name is Abby Winter. I'm a pharmacist at the UW School of Pharmacy, and I also work at all of the Era Living communities, helping with their the outreach from the UW School of Pharmacy, helping to find innovative ways for pharmacists and students to get involved with the different Era Living communities to help improve quality of life and medication use among the residents. So we've got a great relationship, as they pointed out, and it provides me an opportunity to give presentations like this, which I really enjoy. So we will get started. A quick outline, what we'll be going over today. First, just general information about medications in older adults. We'll talk about the AGS, which is the American Geriatric Society Beers criteria. We'll give a little background on it, talk about why it matters to you, and then some examples of medicines that are on what we call this Beers list. I'll then leave you with some action items. So what can you do, and how can you talk to your prescriber or your healthcare team about your medications? And then the final slide will have some resources. So if you have questions, you'll have a place to go to look for those. So first, medication use in older adults. This is an important quote, I think. This is from someone who sits on the board at the American Geriatric Society Beers criteria. So they helped develop this list. And she said, medications play an important role in health and well-being for many older people. And I want you to keep that in mind as we move forward, because we'll be talking about some things that may sound scary, essentially, as far as concerning medications or possible things that can happen with medicines if they're not used safely or not used in the right population. But do keep in mind that we know that medicines are important. So it's always important that you're talking things over with your prescriber, because every patient's care needs to be individualized. So this slide talks about medication consumption. So there was a survey done by the National Center for Health Statistics of older adults, and they were looking at medication use. So who uses medicines, how many they use, that sort of a thing. This picture over on the right, if we look at the very bottom, it says age group. So when we move from left to right, the age is increasing. And then when you go from bottom to top, the different colors represent how many medicines someone takes on a daily basis. So if it's green, it's the majority of those people are taking 0 to 5 medicines. The yellow and orange is 5 to 10, and the darker orange red is 10 and above. So what we see from this graph is that as we age, we're taking more and more medicines. The results showed that about half of people aged 65 and older take 5 or more medicines. So the other thing that was interesting is that 20% of people who are 65 and older have 5 or more chronic medical conditions. So we often know that with more medical conditions, we get more medications. And with more medications, there's more concern for potential issues. The other thing I thought was interesting in this study is that more than 40% of people age 65 and older take at least one over-the-counter medicine and at least one supplement. So we often think of over-the-counter medicines and supplements as being relatively safe because you can just buy them without a doctor's note or prescription or anything. But it is important to note that it is still a medicine and it can still cause side effects. It can still interact with your other medicines. Again, we do know that medications are important. They are a mainstay of modern medicine these days. They're used to help manage a lot of different health conditions, whether it's relieving a symptom you have, reducing your risk of future problems, or helping correct life-threatening illnesses. But medications do come with risks and side effects, which is what we'll talk about today. So there is a concerning thought that maybe with more medicines, we have more problems. That's a potential. One word that we'll use is polypharmacy. You may have heard this before, but polypharmacy by definition is taking 5 or more chronic medications. So chronic medicines, that doesn't mean I take a Tylenol a couple times a month when I have a headache. That's not really a chronic medicine. A chronic medicine would be if you take a pain pill every day or you take a blood pressure medicine every day. So when we talk about polypharmacy, it's often associated with more adverse health outcomes. So some of these adverse health outcomes are listed below, but note that as we add each additional medicine, the risk of potential harm increases. So that harm could be falls, exhaustion, frailty, cognitive impairment, mortality, or decreased physical function. One thing we'll talk about is adverse drug events, or ADEs. Adverse drug events are unfavorable or unintended reactions or symptoms that are associated with the use of a medicine. So in other words, it's harm that's caused by a drug, even if you're using the drug correctly and appropriately at the normal dose. So it's a little bit different than side effects. Side effects we expect to happen from medicines and we can often overcome them, but adverse drug events are usually a little bit more serious or things that should not happen. So how do we relate polypharmacy, so more medicines, with adverse drug events? Polypharmacy leads to more adverse drug events. Adverse drug events are a threat to the health of older adults, especially. So it's noted that about 10% of hospitalizations for older adults are because of adverse drug events. The management of adverse drug events also costs a lot of money. It's estimated it costs the United States over $30 billion, with a B, $30 billion per year. But the good news is that most adverse drug events are preventable. And a lot of what we'll talk about today will be about ways to prevent those adverse drug events. So in order for medicines to work effectively in anyone, there are 4 things that have to happen, and those are bolded here. We call it ADME, A-D-M-E, because that's what each one starts with. So drugs, in order to work, they have to be absorbed into the body, distributed to the parts of the body where they have to work, metabolized, which is a fancy word for a chemical change that happens that either makes the drug effective or helps the drug leave the body. And then the drug has to be eliminated, usually through the urine. We don't want that drug just sticking around the whole time. We do want it to leave. But there are a lot of things that can affect how well your body does those 4 things that make those drugs work. So your body composition, your metabolism, liver and kidney function, different diseases you have, or other drugs that you're taking can affect how well your body does those things that make drugs work. And as we age, there are a lot of changes in our bodies that also can affect how medicines work for us. So as we age, the distribution of fat within our body tends to change a little bit. And there are some medicines that are absorbed into the fat. And so those medicines could have different effects if we know that the fat distribution in your body is different. Your liver function can also change as you age. Usually it's because we have a decreased blood flow to the liver. So there are some medicines that rely on the liver in order to work well. And if your liver is not working as well, the medicines might not work as well. Same goes for your kidneys, maybe with more importance though. We know that for the most part, once you reach the age of 50, your kidney function declines by about 1% every year, even if you're perfectly healthy. So that's one thing to keep in mind, is that a lot of medicines rely on the kidneys. And if your kidney function is declining, that's something that we need to be concerned about. So there's a number of things that we often see patients experience, and we'll say, oh, that's just a normal sign of aging. Maybe, maybe not. Our concern is that it could be a medication side effect. And that's one thing we need to keep an eye on as healthcare providers, and also as patients, or if you're taking care of your loved ones, knowing that there are some medicines that may cause side effects that people just think, oh, they're just getting older. But that might not always be the case. Some of the examples: falls or fractures in your bones, confusion, poor memory, urinary incontinence, constipation, heartburn. Some of these things we think you're just getting older, but it actually could be medication side effects, and we'll talk about that a little bit. I'm going to say it again, individualization is really key. So I need you all to keep in mind that every patient has different goals of care and different priorities, and their prescriber and healthcare provider will be the ones to help determine what those are. But keep in mind as we move forward that the medicines I'm listing and the things we're talking about is not a one-size-fits-all approach. There's really no way to do that. But what it is meant to do is make you aware, or maybe raise a little flag so that next time you go to the doctor, you bring something up if there's something that's concerning. But just because you see a medicine on here that we'll talk about today that maybe you take regularly does not mean you need to stop it, does not mean it's bad for you. It's just something that should warrant an additional conversation. So now we will talk about the AGS, American Geriatric Society, Beers criteria. So what is it? Essentially, it's a list or multiple lists of certain medicines that may not be appropriate or may not be the safest options for most older adults. Again, this is not a do not take list, but it is a list of medicines that may be potentially inappropriate for older adults. So keep in mind, there are a lot of different caveats and different rationales that come with this list, okay? So it's first developed by this gentleman here, Dr. Mark Beers, in 1991. So we titled this presentation, "A Nurse, a Pharmacist, and a Doctor Walk into a Bar," to kind of play on the beer of the Beers list. But as far as we know, he didn't have anything to do with brewing beer. He was not a brewmaster or anything, but the last name probably led him to a lot of jokes about that. But a few things he was. The first medical student to do a geriatrics elective at Harvard on their division in aging, and he also completed a geriatric fellowship at Harvard. So he was really involved in the aging and older adult populations and was really concerned about their medication use. So he developed this list first in 1991, and the goal of it was to decrease inappropriate prescribing and decrease adverse drug events, those things we talked about earlier, in our older adult population. In 2001, Dr. Beers passed away, and that's when the American Geriatric Society took over doing all the revisions and the updates to this list, because as we know, things change regularly. Since 1991, there's so many new drugs and new studies that we needed someone to be keeping up with it. So every 3 years, they get an expert panel together that includes doctors, pharmacists, and nurses. I don't think they meet at a bar, but they get together and they review thousands of studies, compile all their findings, and publish it every 3 years. So just so you get an idea of how often they're meeting and how much work they're putting in, when they did the last update in 2019, they were meeting regularly starting in February 2016 until May of 2018. So they meet a lot. They meet regularly. There's a lot of stuff to go over, but they're the experts in the field, so we're lucky to have them doing this. So why does this matter to you? Well, there are multiple lists or tables. You could think of them as like 5 different beers on tap if you want to play with this beers criteria name a little bit more. But there are 5 lists or tables of medicines that we want to avoid or use with caution in certain older adult patient populations. So the first list is drugs to avoid by most older people. The second is drugs to avoid by older people with specific health conditions. The third is drugs that we want to avoid in combination with other treatments because there could be interactions between the drugs. The fourth one is medicines that we want to use with caution because they might have potential harmful side effects. And then the last one is medicines that we might want to dose differently or avoid in people whose kidney function is reduced. So you might think back and say, doesn't everyone's kidney function reduce? It does, little by little. But the ones we're really concerned about here is if your kidney function is significantly lowered. Maybe you've been diagnosed with chronic kidney disease, or your doctor said something about a certain level that they're concerned about. That's the main population. So why does it matter to you? Are you an older adult with a health condition, on a medication, or your kidney function is declining? Then the Beers criteria probably applies to you or your loved ones. Again, remember, it's not a one-size-fits-all. Every recommendation needs to be evaluated and individualized for each patient with your care provider. So again, these are potentially inappropriate medicines, potentially inappropriate. It's not a replacement for the expertise and knowledge of your healthcare provider. So let's talk about some examples. So these next few slides might feel a little bit overwhelming. What's hard here is that there are quite a few medicines on this list, and there's quite a bit of rationale and discussion. So it might say drug A is on the list, but only for patients with this, and only if we're concerned about that, and then have a talk with your doctor. So it's a little difficult for me to just list all of the medicines. So what I tried to do was pull out ones that are more commonly prescribed or more commonly used. So there may be some medicines that I've left off this list, but it also contains some medications that you might see it and say, oh, I'm on that medicine. But remember, there are caveats and rationales that go along with it that, again, it's a flag to warrant a conversation with your doctor. The other thing to keep in mind, I might say something like antidepressants fall on this list. That does not mean all of them do. There are certain ones, and I'll try to list the most common ones. Again, there's just a lot of caveats. So if you are listening to this and you get a little bit concerned or it raises a flag for you, I'd encourage you to speak with your doctor about it. So first we'll look at the list of medicines that are commonly prescribed that are, quote, potentially inappropriate for use in most older adults. So first we'll talk about what are called antihistamines. So these are usually, you'll think of them like your allergy medicines, that sort of thing, but not all of them. It's the first generation ones. And I know that sounds a little confusing, but that just means the ones that are more likely to cause a little drowsiness. If you see anything in bold, a drug name in bold from here on out, so that darker, bigger font, that means it's available over the counter. So I want you to have a particular caution with it because it's something you could be taking without anyone else knowing, and it's important that you'd let your doctor know. So the big one that we often hear about is Benadryl or Diphenhydramine, because if it makes you a little bit more drowsy, you have an increased risk of falling, which could increase your risk of a fracture or feeling confused or dizzy. Doxylamine, you might not recognize that name, but it's in a lot of what we call like nighttime cold and flu medicines. So if you see something with Vicks or Robitussin, even that Coracidin high blood pressure cough and cold medicine can sometimes have doxylamine in it. So I always say, look for the ingredient list, especially if it's a combination cough and cold product. Hydroxyzine is another one. Meclizine, this one's interesting because it says it's called Dramamine less drowsy, but it can still make you drowsy and still cause those side effects. And then promethazine, or Phenergan is the brand name. We often see that one in combination with codeine as a prescription cough medicine. On this slide, we have a list of medicines that are often used for cardiac or heart concerns. So alpha blockers, but only if it's being used to treat high blood pressure. So there may be other things we use these medicines for that it's completely safe. But if you're an older adult and it's being used as the first thing to treat your high blood pressure, we're a little bit more concerned. Those examples are doxazocin, crazocin, and terazosin. Alpha agonists like clonidine, guanfacine, methyl-dopa, or reserpine are also of concern, as well as digoxin. So digoxin, if it's the first thing we use to treat your heart failure, we want to make sure we try other things first, usually, but it is okay to use, we just need to monitor the dose very closely. Nifedipine is also of concern, but only the immediate release. If it's an extended release form, we're less concerned. And then amiodarone, but again, only if it's the first thing used to treat your atrial fibrillation. So if you don't have AFib and you're on amiodarone, it may or may not be inappropriate for you. So this just gives you a taste of how there's a lot of complexity that goes along with this list. And again, I can't just say, don't take nifedipine. We need to make sure that you're having this discussion with your doctor. Next is some medicines that affect your central nervous system, or your central nervous system I think of as your brain function. So there are some antidepressants, not all of them. These are the ones on the list that are most common. There are a lot of other antidepressants that are commonly used that do not fall on this list, but amitriptyline and nortriptyline, or Paxil, which is paroxetine. A big thing I want you to remember moving forward, I'm going to mention benzodiazepines quite a bit. Benzodiazepines have even come out in the news a little bit more recently as being really a drug of concern. Benzodiazepines are often used for anxiety, or sometimes inappropriately so, they'll be used for sleep. You may have heard of the drugs Xanax or Valium or Ativan, that's your alprazolam, lorazepam, clonazepam, diazepam. You can see we've got a pattern there. Benzodiazepines are really of concern, and it can lead to make you feel pretty drowsy or dizzy, a little bit loopy, and that can lead to more problems. Next is antipsychotics. So if we're using it to treat schizophrenia or bipolar disorder, that's fine, it is safe, but often we'll use these medicines for other things, and that's when we get a little more concerned. So things like Haldol or Abilify, Risperidol or Seroquel are common ones. And then these Z drugs, we'll bring this up again later too. Z drugs are other sleep medicines. So maybe think of, when you think of sleeping, we think of catching some Z's. Z drugs are some of these sleep medicines like Ambien or Sonata. Those we do find some concern because even though it might help you fall asleep, it can often make you drowsy the next day too, or you might have some brain fog that you don't realize. And that can lead to potential problems. Next is some medicines that affect the endocrine system. So endocrine is your hormones. Testosterone is one of our higher risk medicines, unless someone has an actual diagnosis that's confirmed of hypogonadism. Using it for something else, we want to take another look at it. Estrogens, which we do commonly see in older adults, we want to use with caution. We want to avoid what we call systemic, where you take it by mouth and it goes to your whole body, because then it can affect a bunch of different parts of your body. But if we're using a topical or like a vaginal cream or tablets, and it's a low dose, it's only acting locally wherever you put it, those are a little bit more acceptable. This one might concern some people when I say insulin, but our concern here is sliding scale insulin. It's not just if we have you on a dose that changes. Our concern is if you're only on that rapid acting, that fast acting or mealtime insulin that changes based on your blood sugar, and you are not on a long acting insulin with it. So if you're on a long acting and a short acting, we're not as concerned. But if you're only on that short acting, that's where we get a little more worried, because a low blood sugar is actually more dangerous right now than a high blood sugars are in the long run. And then sulfonylureas are another type of diabetes medicine. Glyburide and glimepiride are the ones you may have heard of. These can cause your blood sugar to drop too low, especially as we get older, because they often rely on your kidneys. As far as some GI or gastrointestinal medicines, we're concerned with metacopamide and then proton pump inhibitors. So you'll see some of these are bolded: omeprazole or Prilosec, pantoprazole or Protonix, and Nexium. These are available over the counter. We do have some concerns with these, especially if they're being used long term. So always bring that up with your doctor. They're ones that we would use for like heartburn or GERD if you have it. And then pain medicines. So with pain medicines, there's an increased risk of bleeding in your GI tract, or an increased risk of peptic ulcer in our older patients 75 and older, especially if they're on other medicines too. So we want to be concerned there with chronic use of these medicines especially. So if you're just taking an Aleve or an Advil a couple times a month when you've got a headache or pain or something, we're not as concerned. But if you're relying on your Aleve every day, or you need your Advil 4 times a week, we're a little more concerned. a baby, quote, baby aspirin, or that 81 milligram, or the low dose aspirin every day does not fall in this category. That's different. We're using that for your heart. And then at a lower dose, it works differently. Next are muscle relaxants. So things like Flexeril or methylcarbamol. Muscle relaxants can also increase your sedation or how tired you feel, increases your risk of fractures. So we want to use those in caution. Okay, so that was a lot. The list I just went over is, again, what's potentially inappropriate for most older adults. Now we'll talk about medicines. If you have a certain health condition, there are certain medicines that don't really work well with that health condition. So we'll break that down. If you or a loved one has heart failure, we want to avoid our diltiazem, verapamil, and NSAIDs. Those NSAIDs are, again, like our Advil, Motrin, Aleve, that sort of thing. If you or a loved one has delirium, we're more aware of our antipsychotics, those benzodiazepines, which we talked about, like our anti-anxiety medicines, like Ativan or lorazepam or Xanax. Corticosteroids, so the common ones would be like prednisone or methylprednisolone. And then H2RAs, these are available over the counter. This is our famotidine or Pepcid and ranitidine or Zantac. We get a little more concerned with those if someone has delirium. If you or a loved one has dementia or cognitive impairment, we're really concerned with our benzodiazepines and antipsychotics, so other things that affect the brain. And then if you or a loved one has a history of falls or fractures, we're concerned with our anti-epileptics. This is our anti-seizure medicines, our antipsychotics, again, things affecting the brain, our benzodiazepines, again, things that make you tired. Multiple types of antidepressants are a little more concerning here. So we usually say we try to avoid them if there's no other safe alternative, unless there's another safe alternative. But some examples would be like nortriptyline, and then Prozac, Lexapro, Zoloft, Paxil, Effexor, Cymbalta. Those we do use in caution if you have a history of falls or fractures, but they're not ones that are of concern for the general older adult population. Then lastly is opioids. You might be seeing opioids in the news a lot lately over the last few years. Our concern there is they make you pretty drowsy, dizzy, loopy. I know when I broke my foot once and I had an opioid and I took half of the pill the doctor told me to, and I fell asleep right away and I was really loopy. I could barely walk to the kitchen. Some people don't have that effect. Some people can completely tolerate them, which again is why you need to talk to your doctor. But with opioids, it can make you a little dizzy or drowsy. You're more likely to fall if you're trying to walk and you're a little wobbly. If your loved one has Parkinson's disease, we're more concerned with antiemetics. Those are ones that we use for nausea or vomiting, like metacopamide or promethazine, and antipsychotics. If you have a history of gastric or duodenal ulcers, our aspirin at a higher dose, so we're okay with the baby aspirin or the low dose, but higher dose aspirin and other NSAIDs like Advil or Aleve, we're more concerned because they can also make ulcers worse or can cause new ulcers. If you have been diagnosed with chronic kidney disease, so stage 4 or higher, or a lab that they'll draw is a creatinine clearance, if it's less than 30, our NSAIDs are really concerning. So I know NSAIDs have come up here a lot. Usually our concern is chronic use in most older adults, but in certain health conditions, if you have that diagnosis, we want to look at them with a little more caution. If you have urinary incontinence, or in women specifically, some estrogens, and then doxazocin, prazosin are other things that we're concerned about. So let's say you're on one of those medicines, but you don't have urinary incontinence, might not be as concerning. Next are medicines that if your kidney function is low, so you have chronic kidney disease, or if your doctor has told you your creatinine clearance is lower, or we're trying to keep an eye on that, these are medicines we want to be a little bit easier. There are a couple of antibiotics that aren't great with poor kidney function, or we might have to change the dose. So again, this doesn't mean you can't take them. We just need to be more concerned about the dose. So Cipro or ciprofloxacin, and Bactrim, which is one of our sulfa antibiotics, is affected by your kidneys. So are some of the central nervous system medicines, or things that work on your brain, and pain medicines like Cymbalta. Gabapentin is a common diabetes or nerve pain medicine. Keppra is an anti-seizure medicine, but we use it for other things. Lyrica or Tramadol, which is a pain medicine. There are a bunch of different heart medicines that can be concerning with kidney function. And I also want you to be aware, when your doctor starts a medicine, checking the kidney function is, especially as we age, is usually an automatic thing they do. Pharmacists especially, we are constantly worried about the kidneys and what medicines a patient is on. So especially in a hospital or in a facility where they're reviewing your medicines and have your labs, that's easy. But if you're going to a community pharmacy outside, they might not have your kidney function on file. So we'll talk in a little bit how to bring up those concerns if we need to, but certain blood thinners like Eliquis or Pradaxa or Lovenox can be of concern, also spironolactone or triamterene. And then famotidine and ranitidine, which are also available over the counter, they're ones that we could also use for heartburn, could cause some issues if you have kidney function decline. Okay, and this is a bonus table that I did not really mention, but I think it's important we keep an eye out. So there's a certain type of medicine that we call medicines that have anticholinergic properties. Excuse me. So it's certain side effects that they have that taken alone are probably fine. But if I take 3 or 4 or 5 medicines that all have these anticholinergic side effects and we put them all together, it can make it really bad. So these medicines on their own may not be bad, but if you're taking multiple things on this next slide, that's where we'd want to have a conversation. So if you're on amitriptyline, nortriptyline, or Paxil, a couple of anti-nausea medicines like prochlorperazine or Phenergan, some antihistamines like we talked about early on, like Benadryl or chlorpheniramine, the doxylamine or meclizine, Dramamine less drowsy, oxybutynin or tolterodine, which are urinary incontinence medicines, a couple of specific antipsychotics like clozapine or olanzapine, some antispasmodics like atropine, belladonna, or scopolamine, and then the muscle relaxant Flexeril. So let's say you're on 1 or maybe 2 of the medicines on this list. Not as concerning, but you might want to keep an eye on it. But if you notice like, oh, I'm on 4 or 5 of these, you might want to jot them down or be concerned with the word anticholinergic, and that would be something to bring up with your doctor. So what's the overall conclusion here? Because I just spewed off, a bunch of things that may have sounded like gibberish, understandably. Things that I want you to pay close attention to. This is kind of a summary. Medicines that affect the brain. So you might not be taking it for anything related to your brain, but know that anticholinergic medicines, that list we just talked about, benzodiazepines for anxiety or sleep, those sedatives or Z drugs for sleep, and antipsychotics, those are all things that affect your brain. We're concerned about those. We're concerned about NSAIDs, which are non-steroidal anti-inflammatory drugs like aspirin, Advil, Aleve, Motrin, especially long-term use. Muscle relaxants, blood pressure medicines because we don't want your blood pressure to go too low. Blood sugar medicines because we don't want your blood sugar to go too low. Some antidepressants, over-the-counter medicines that say PM or sleep, and estrogen. So this is kind of our big summary slide that I want you to keep an eye on. Okay, so I went over a lot there, but I am going to pause for questions, see if there's any questions that have come in so far in the chat. I'm happy to address them, or if anyone wants to unmute and ask a question now, we'll stop for a couple minutes. Has there been anything in the chat? Doesn't look like it. Oh, something may have just come through. Great, so here was one question that came in. They said, what about lisinopril and amlodipine for high blood pressure? So In general, both medicines are considered safe. They are good, especially if your doctor is monitoring certain other labs that we want to look at while you're on those medicines. They do not necessarily fall on the list of, this is raising a flag for me. The only concern would be, as we add more and more and more blood pressure medicines, we want to make sure that your blood pressure doesn't drop too low. So almost without question, every time you go see a care provider, they check your blood pressure. And that's the best thing that will keep you safe, because with blood pressure medicines, we're just trying to make sure that it doesn't drop too low. Another thing your doctor might recommend is checking your blood pressure at home, because often if you go to the doctor, you are stressed out from the drive over, you couldn't find a parking spot, you were rushing to get there, and that may affect your blood pressure when you get to the doctor. So if we know what your blood pressure looks like at home, it can be a little more normal. That's maybe a better way to assess blood pressure. But in general, those medicines don't raise a flag to me. But if you are concerned about your blood pressure dropping too low, that's when I would talk to your doctor. Any other questions before we move on? And I'll look back at the chat in a little bit too, and we'll have some time later on. Did someone just unmute? Did they have a question to ask?
Yes, my wife and I generally go to PacMed. We always go to PacMed, and they're very, very thorough about checking our medicines every time we go. And if they send us a new prescription like to Safeway, you know, I assume that the pharmacist is checking it there. But the mail order place, Maxor out of Texas, are they cross-checking my medicines?
Great question.
Like a neighborhood pharmacist would?
Yeah, great question. So any pharmacy that dispenses a medicine to you is checking with other medicines that they also dispense to look for what we call drug-drug interactions. So let's say you get all of your medicines in the same pharmacy, they can see everything. If you get half your medicines mail order and half your medicines at a local Safeway, they might not see what other medicines you're on. So that's when it's important to make sure that your doctor knows everything you're on, even if a different doctor prescribed it. And we'll talk about that too. The other thing though is most pharmacists will always do a check, not just drug to drug, but they'll say, this patient is this number of years old. Are these medicines appropriate for them? We always have, these pharmacists always have this Beers criteria kind of thing in their head. If they don't have reference or access to your lab values, we can't always check, you know, is it safe with your kidneys? But for the most part, if a pharmacist has a concern, they're going to reach out to the person who prescribed the medicine. So that usually happens on the back end. You might not even know that your pharmacist reached out and talked to your doctor, but that's the work that we're kind of doing behind the scenes. So whether you get it from a mail order pharmacy or from a discharge at the hospital, or you get it from the pharmacy down the street, the pharmacist's job is to review all of the medicines that they know of that you're taking and make sure that based on the inferred disease states you have, it's safe. Based on your age, it should be safe. And if they have a concern, they'll usually bring it up with your doctor before it goes out to you. Yeah. What other questions can I answer?
I would like to know what are your thoughts about Tylenol, and especially as it relates to other medicines like blood pressure medicines?
Great question. So Tylenol is not really a medicine that raises a flag or is on one of these lists. So when we're talking about pain medicines, the biggest concern is what we call those NSAIDs. So our Advil, ibuprofen, Motrin, and those work differently than Tylenol does. Tylenol works in a totally different way, usually a little bit safer. Often the big concern we'll have with Tylenol is with liver function. So that's why you may have heard, you know, they'll try to avoid drinking alcohol and taking Tylenol. It kind of stresses your liver a little bit. But you said kidney function, is that correct? Was that your concern? Or Tylenol
with blood pressure medicine?
Blood pressure, thank you. Okay. So not much of a concern there. But if you're ever concerned about a particular medicine or anything like that, if you're taking Tylenol just infrequently as needed, talk to your doctor about it. But for the most part, Tylenol does not pose that same concern that those other over-the-counter pain medicines like ibuprofen and Motrin pose. Good question. Got another one in the chat. What's the blood pressure goal? So that is not actually an easy question to answer. Every patient is actually a little bit different because it depends on what disease states you have. So if your only diagnosis is high blood pressure, then your doctor might have a more strict goal for you. If you have another condition like diabetes, we might change what your goal is. If you have diabetes and your age is above a certain number, your goal will change a little bit too. So every patient's blood pressure goal is actually a little bit more individualized than we might think. You know, often people are saying 120/80 is what we would think of as that goal, but that's actually where we would diagnose. Once you have high blood pressure or hypertension, then we give you a little bit of wiggle room. We want to keep it under a certain amount. But in our older adults, our concern in the short term is actually a lower blood pressure. If we lower it too much, that's more concerning than having a higher blood pressure for a long period of time. So I'm sorry, I can't give you a direct answer there, but it's always a great thing to check with your doctor and just say, you know, based on my age and my other diagnoses, what should my blood pressure goal be? And they'll give you a better idea there. So I'm sorry, I can't give you a straight answer. I know that can be frustrating, but there's lots of caveats. Any other questions? All right, hold on to them if you have them. Type them in the chat at any time and I'll check them towards the end. And then we are going to move forward with the rest of this presentation. I'll ask if you did unmute yourself to go ahead and mute again, just to make sure that everyone can hear as we move forward. So great questions though. All right, so now we're going to talk about action items. So you got all of this, you've got your concerns, now you don't know if my medicine is safe, or you know, you saw a couple of your medicines on this list, but you're not sure what to do. So what are we going to do moving forward? First of all, do not stop any of your medicines without checking with your care provider first. Okay, so I don't want this to serve as your reasoning for stopping a medicine. Most of the time, we hope that the trust that we have in our prescribers and our doctors, they're looking at your medicines, they're looking at your history, they're looking at you as an individual, weighing those pros and cons to decide if a medicine's appropriate or not. There may be things that they miss. There may be changes to your healthcare that they don't know about, your health status that they don't know about, that suddenly makes the new medicine not as appropriate. So always talk to your doctor. Don't just stop your. So what can we do about adverse drug events? Remember, with every medicine that we add, your chance of an adverse drug event increases. So when a medicine needs to be added, don't be afraid to ask questions, especially if it's a medicine that you saw on this list or a medicine that you're concerned about. Because if we can reduce the number of medicines folks are on while still maintaining appropriate health and appropriate management of symptoms, that's our goal. Fewer medicines while still keeping you healthy. So what questions should you ask when you're starting a new medicine? And who do you ask? You can ask the person who's prescribing it, so your doctor or nurse practitioner, or you can ask the pharmacist before you pick it up and actually pay for it and take it. What's the harm if I don't take it? Because for some people, we might think the doctor prescribed it, I have to take it. But there could be a reason when you may or may not want to, and you want to have that conversation with your doctor if you're concerned. Also ask, how will you know if it's working? Ask what side effects you should watch out for. Ask if the medicine will interact with the other medicines you're taking. And as we've talked about already, your pharmacist, if they dispense all of your medicines, they'll be able to do that check for you. Your doctor, for the most part, should know what medicines you're on and usually has that inherent check as well. But asking explicitly, asking outright, will make them take a second look and help keep you safe. Ask if this medicine will affect any other medical conditions you have. Ask if there are any alternatives. And we'll talk about alternatives in a little bit too, but an alternative could be, you know, I'm deciding between these 3 medicines, I think this one's best for you. Ask them what the other ones were and why they didn't go with it. Or they may say, we could try this lifestyle change or just start a medicine. Talk with your doctor about that and see if there's other things that you could try first if you're worried about starting a new medicine. So some simple steps you can take. Regularly review all of the medicines you're taking with a healthcare professional. So that can be your pharmacist, that can be a nurse or something that you live or work with, or that could be your physician or your doctor, your primary care provider. Ask them explicitly, are there any drug interactions? Are there any unnecessary medicines? That's one thing that often happens. Maybe we add a medicine. The reason you're taking it could have gone away, but you're still on that medicine. Or your labs have changed a little bit and a medicine may or may not be appropriate any longer. So asking if there are any unnecessary medicines triggers that healthcare professional to look at your medicine list in a different way. Also, it's always important to remind whoever's reviewing your medicines to consider your age when reviewing it. So I'll be the first to admit, I'm not great at guessing people's ages. I'm not great at kids, I'm not great at older adults. And someone could walk into the pharmacy and say, consider my age when I'm reviewing this. And they could be 50 and look 80. They could be 80 and look 50. And that could change how I would approach their medicine list. So remind your healthcare provider to consider your age when reviewing your medicines as well. You can do your own due diligence by keeping an eye out for higher risk medicines, and don't be afraid to ask about alternative options. However, alternative options could mean a different prescription. So you'd still be adding a prescription, but could talk about the pros and cons of that medicine. An alternative option could mean an over-the-counter medicine. It could mean a non-pharmacologic, so not a drug. So let's say it's a sleep medicine that we're concerned about. If you ask about alternatives, they might talk about something called sleep hygiene, which is different activities you can do at home, not looking at screens after a certain period of time at night, not having TV in the bedroom, things like that. They might talk about that instead of starting a drug. So some of those things may or may not be as effective as the prescription too. So just know if you ask for alternatives, it might not be what you want to hear, but it's a good way to open that discussion up. Talk about that in a minute. So in order to review every medicine you're on, we need to keep a list of all of the medicines you take. So hopefully that's something you have, or maybe your doctor's given to you at one point. And if you don't have it, now's the time. This is your triggering event to remind you to get that med list and keep it updated regularly. So maybe you keep this list in your wallet, or if you have a smartphone, you can put it in your notes section on your phone, or write it out and take a picture of it on your phone, just something to have with you regularly. So maybe you have an emergency, you can whip that out and show the healthcare professional that's helping you. Or maybe you're at the pharmacy and you've got a bad cough or cold and you need a recommendation. It's not your normal pharmacy. You can pull that med list out and ask the other pharmacist, hey, based on these, can I take this other over-the-counter medicine? So having it available is important, but also to provide to your doctor. We'll talk about this too, but don't just assume that all of your prescribers talk to each other. These days, we see different specialists for different things. Even if they're all at UW, or even if they're all at the polyclinic and they use the same charts, they might not notice when a change was made. So you need to update your list regularly if you can, and make sure everyone you see for healthcare knows your changes in your medicines. So think of it this way. Your list should include anything you ingest, inject, inhale, or apply to your body. Everything goes on that list. I don't necessarily need to know about your moisturizer, but I do want to know about your steroid cream or something like that. So don't forget vitamins and supplements, natural medicines, herbal products. Just because they're natural or herbal, or you picked it up without the doctor writing a prescription, it can still have effects. It can still interact with medicines. It may not be safe for you. Also, don't forget devices. So inhalers, nasal sprays, injections, topical stuff, all of that needs to go on your list. And then in this purple box, I put down in bold important things that you should have for every medicine if you're able. So the name of the drug, the strength, which tells us how many milligrams or micrograms or units, the formulation, which is it a tablet? Is it a capsule? Is it a liquid that you drink? Is it a patch you put on your body? Is it an injection? Tell me how you take it. Tell me how many you take at a time. So if you just told me I'm on metoprolol 50, do you take one tablet? Do you take 2 tablets? Do you take 2 tablets twice a day? Do you take 1 tablet 3 times a day? All of those mean very different things. So the name, the strength, how many you take at a time, and how often you take it. Okay, all of those things are important for every single medicine. So I don't just want to see your list that says vitamin D, calcium, metoprolol. I want to say vitamin D, however many units, 1 tablet, 2 times a day. That'll help everyone be able to get a better idea of the big picture so they can help you stay safe. I also want to make you aware, we are going to be able to send out these slides after the fact. So if I don't want you to be worried about seriously writing something down, or if you have a concern, we'll be able to get this to you for a reference. Okay, so now talking to your prescriber. Again, make sure every doctor knows every medicine you're taking. Don't assume they talk to each other. Don't assume that they saw or realized that there was a change to your medicines. Sometimes you have to be your own advocate. It's usually better if you keep all your doctors the same and they share the same records. Hopefully they're able to see that stuff, but doctors are busy and there's a lot of things going on that, you know, when they say, how have you been? Anything changed recently? Make sure you've got that in your head, like, oh, well, here's my updated list, so they'll be able to see. So I've said it a million times today, talk to your doctor about it, talk to your doctor about it. How do you talk to your doctor about it? This is not a thing that's easy for people to bring up. It's feels like a new language sometimes, talking about these drugs, and they've got so many names and so much going on. So how do I even begin? First, when you're talking to your prescriber, when should you do it? If you're concerned about a medicine. Maybe you don't think it's working. Maybe you're having a side effect. Maybe it was on one of these lists we talked about today. That's a good time to bring it up with your doctor. So how? Ask specific questions, kind of how we alluded to today, but ask, is this safe for someone my age? Is this safe for someone with my health conditions? Is this safe for someone with my kidney function? Is this safe with the other medicines I'm taking? So those are important things to keep in your mantra as you're moving forward talking about these medicines. I will tell you, for the most part, these are things pharmacists are always looking at, but it's always a good idea to give them that little extra boost or reminder. Ask if there are possible alternatives. So just because it's on this list doesn't mean you can't take it. It may still be the right medicine for you. And then we already talked about how possible alternatives could mean a plethora of things, so just be aware. It might not be just another drug they prescribe. It could be, here's something you can try at home first before we try a new medicine. Again, remember, medical choices and medical care and medicines are meant to be individualized. So your diabetes is not the same as Ed's diabetes, and Suzanne's blood pressure is not going to be treated the same way Sarah's blood pressure is. So keep that in mind as well. You can't always compare with your friends or other family members. Your doctor will be the one to assess the risks and benefits. So your friend Susan's doctor might say, nope, I really want you on this medicine, even though it's on the Beers criteria list. But your doctor might say, oh, you're right, it's on the Beers criteria list. We shouldn't use it. We have other options. And both are okay. This might feel a little mushy-gushy for some, but let your doctor know how you feel about your medicine. That's really important, and let them know what's important to you. So here's some questions to ask yourself, and then share that, your answers or your thoughts about it with your doctor. So are you concerned with the number of medicines you take? Is it hard for you to remember to take or keep track of all your medicines? So let's say you're really good with your breakfast and dinner doses, but you always forget lunchtime. Let your doctor know. Are there any medicines that are really important to you? And if so, why are they important? What are the main reasons you take your medicine? So really think about that. Is it because you think you have to? Because this person with a medical degree told you to? Is it because your family says you have to? Or do you understand, like, this is how my medicine works, it's important for me, and I know why it helps me? Think about that. And if you're not happy with some of those answers, it's a good thing to bring up with your doctor. Also, ask yourself, how does my family feel about my medicines? So, you know, my great aunt might not be the best one to ask about this, but maybe my partner who lives with me, or my son or daughter, or someone who's helping manage my medicines. How do they feel about your medicines? Do they think they're all important? Do they think you're on too many? Do they think you should be on something that you're not? Cares about your well-being? They'll have a good answer to that that might be worth bringing up. Also important to, is it a burden to you? Is it something you can't afford? You know, there are a lot of alternatives and a lot of help out there as well if you can't afford your medications. No prescriber, no physician, no one in the healthcare field wants their patients to go broke trying to stay healthy. So it's important that you bring that up if you have concerns. And then lastly, are there any medicines that are a burden to you? And if so, why? Maybe it's difficult to take, you can't swallow it, or the device is really hard to use, or maybe the pharmacy never has it in stock, so you miss your medicine half of the days because you don't have it at home. Keep those things in mind, jot those notes down when you think about it, and bring it into your next appointment. Okay, so here's a few additional resources. The most important one I want you to remember is that first one called healthinaging.org, all one word, healthinaging.org. Capitals don't matter, or lowercase. But this one's really great. It has a lot of patient-friendly information, a bunch of different chronic diseases it touches on, age-friendly healthcare, and resources about wellness and prevention. And then the National Council on Aging has some other resources as well. It may direct you back to Health in Aging, but that's a really good resource I like to recommend to our patients and residents as well. So with that, I'll open it up for final questions. I know we're kind of at the end of our time here. I did see a couple come in the chat. About Warfarin, what's the best multivitamin, and then, okay, so I'll start with comments on finasteride. It's really difficult to give individualized, I'm gonna stop sharing my screen actually real quick. It's really difficult to give individualized recommendations in a setting like this, unfortunately, because as I've mentioned, there's so many different components that go into it. I need to know your age, I need to know your other health conditions, how long you've been on it, what dose, what other medicines you're on. So if you have a concern about a specific medicine, again, use those tools and resources we talked about to have that discussion with your provider and figure out what your real concern is. Is it because of your age? Is it because of side effects, other medicines? And ask those specific questions to your doctor. And then someone asked what my thoughts are on natural versus prescription medicines. So I'm assuming you mean natural, like herbal products or supplements or vitamins. So there is a time and a place for both types of medicines. The FDA does not regulate in any way anything that you buy over the counter that's a vitamin or a supplement or an herbal product, which is kind of scary for some people to realize, but they don't say it's safe or effective. They actually can't even guarantee that if it says it has, 40 milligrams of the drug in there, it may not, which is actually really scary. So there are certain things that you can look for if something has a USP, so U for unicorn, S for Sam, P for Paul, USP certification on it or a stamp on the bottle, then we know that it went through a third party that said, yep, this is safe, it contains what it says it contains. Those can sometimes be a little bit more expensive than like the generic Walgreens vitamin D, but if you're worried about that, it's something I think is important because no one is checking what's in that bottle, no one is saying that it's safe or will do what it says it will do. However, there are a lot of natural medicines and supplements that are definitely appropriate. I think that there's ways that they may work best in combination with certain prescription medicines. It depends on what we're trying to treat. If you have a very high A1C and really high blood sugars and you're trying to treat it with just cinnamon, it's probably not going to work. Your cinnamon might help in addition to your prescriptions, but then we need to look at the cost benefit there too. So if it's not causing you harm and it's not causing you to go broke, I'm okay if patients think cinnamon helps their blood sugars, but also know that these prescription medicines are regulated. They have been heavily tested, shown that they're going to do what they say they're going to do. And that's something to keep in mind. But again, there's definitely a time and a place for all of them. And that's a great thing to bring up with your doctor to open that conversation. I usually ask if someone says, oh, when I take this vitamin and this supplement, I say, why? A lot of times they'll say, oh, they say it's good. Well, who says it's good and good for what? You know, think critically about it. Just because you see it on an infomercial or Dr. Oz says to do it, might not be best for you, because those commercials, and they don't know you and your specific health concerns. But most prescribers are open to the idea of natural medicine, so keep that in mind. Then we have one here. If someone's on warfarin, what's the best multivitamin to take? I can't necessarily recommend a specific product, but the thing with warfarin, we know it can interact with a lot of different drugs. And the key is to keep everything consistent. So if you've already been on a certain multivitamin, staying on that multivitamin is probably best. Whenever you change a medicine, that's when you need to let your doctor know, because we might need to monitor your warfarin a little more closely. If you're not on a vitamin and you want to start one, let your doctor or whoever's monitoring your warfarin know that you want to start a multivitamin, and then they'll probably check your levels a little bit more closely. They might need to change the dose of the warfarin, but that's one thing to keep in mind, is consistency when you're on warfarin. But there's not really one vitamin that's better or worse than another when it comes to that. But there are some that are marketed for folks who are over 65 or over 50. That's usually one I'd recommend. And then what's the current thought about the use of statins in older adults? Great question. So it depends on why you're taking the statin. So statins are types of medicines that help lower your cholesterol. But in the last maybe 5 to 10 years, there's been some other data that's come out that says statins are good for certain patient populations, even if your cholesterol is perfectly normal. So even if your cholesterol is not high, there's been studies that say statins are really good and beneficial for a lot of different patients above a certain age with certain health conditions, because it helps prevent future heart events from happening. So if you're taking it just to prevent, we always say as we age, reevaluate. You know, if maybe your life expectancy is only, depending on other conditions you might have or something, maybe your life expectancy is 5 years and this drug is meant to prevent your 10-year risk. Is it worth it to still take this medicine? If it's not causing you any trouble, it's relatively inexpensive and you don't have side effects, the answer might be, yeah, it's still worth it. But if you're having side effects from it or something, that's another thing to bring up. But usually we say as we get older, you know, over 75, we'd reevaluate, over 80, we'd reevaluate. Because at that point, lowering your cholesterol to a certain value may or may not have the benefit that we really need in the future. If we're doing it because you have a high cholesterol number and we're trying to bring that down, it could help prevent short-term things and long-term things from happening. So for the most part, statins are probably considered relatively safe, but we need to monitor the dose, make sure that you're not having side effects that could be related to it. A good question. That's, I think, a thing to keep in mind is as we age, we need to reevaluate those medicines. You may have been on this medicine for 30 years and been completely fine and safe. And then once you reach a certain age, your kidneys get to a certain place, the medicine might not be as safe for you anymore, or we need a lower dose. So having that conversation with your doctor is important. Right, those are all the questions that came up in the chat, and I know we're about 10 minutes over. I do want to be respectful of time. I'm happy to stick around for a few minutes if there are other questions that folks have who are on the call.
Any questions out there from anybody else? Go ahead and unmute yourself if you'd like to ask any questions.
I have a question if nobody else does.
Please do.
And this is not particularly taking it, but I happen to be a pension actuary, and about 10 years ago, I wrote a monograph on why women live longer than men, of which there's lots and lots of reasons, genetic, animals, pre-birth, all kinds of things. And there was a very interesting study done, I think in the 1950s, when early in this century, one of the ways of dealing with mental illness, serious mental illness, was castration. And a PhD studied this population for life expectancy, and very surprisingly, the castrated men lived surprisingly longer than intact. Ever since I read this study, which is it's pretty overwhelming evidence. Every time I hear an ad about, oh, take testosterone and you'll be strong, I think, oh, there goes another couple of years of life. Is that the reason that testosterone's on there, or is it something completely different?
I actually don't know that I can speak to that specifically. I don't know that they reference that study. I'd have to look back for sure. I think that some of the concern is with additional hormones. We have concerns with, bone health and things like that as we move forward. And I will say, I know that when they review for the Beers criteria every 3 years, there's tons of studies they look at. Usually what they're looking at is things that are controlled, like this patient population was on testosterone and this patient population was not. Let's compare what happened. And so and usually the Beers criteria medicines are not because of life expectancy as much as they are with some of those adverse drug events we talked about, like frailty, falls, confusion, that sort of a thing. But that's a really interesting thing that you brought up. I wouldn't be surprised if there was some relation, whether we know what the cause was or not. The studies that they're looking at, though, are probably a little more drug specific. So,
okay, thank you.
Yeah, good question. Anyone else?
Any more questions before we wrap up here, folks?
They also, when we send out those slides, I'm happy to provide my email address in there too if you have questions. Again, it's a little tough for me to give specific health recommendations. That's not, unfortunately, something I'm really able to do. But if you have general questions or confusion about some of the stuff I talked about today, I'm happy to be sought out via email. But I really appreciate you guys tuning in today and engaging with your questions. And that's, it's been really awesome to have this back and forth conversation, and hopefully provided you with some good information or sparked some interest or light bulb so that you can have those conversations with your healthcare team.
Yeah, this is great. Abby, thank you so much for your time and expertise today, along with all the really important information that you've been providing in this presentation. As Abby mentioned, we'll get her slides out to you as soon as we get them, and then we are also videotaping this recording so we can get this out to you as well. I just want to kind of re-emphasize our appreciation for the incredible partnership that Era Living, our parent company, we have 8 communities, Era Living and the UW School of Pharmacy, School of Social Work, and School of Nursing has. In particular, with the School of Pharmacy, it allows us to have a pharmacist come to our community and work with our nursing staff. They'll review medication lists for not only our assisted living folks, but they do it with our independent living folks as well. And there's no charge for that. It's completely complimentary, but it's all due to the great partnership that we have with the UW. And we appreciate it so much. And Abby, appreciate your time here with us today. It's a great partnership that we really appreciate. A reminder to everybody also, we'll send out a little survey about your experience on the Zoom event today. We continue to experiment with options and optional ways to present information during this time of restriction with COVID-19. And we want to thank you so much for joining us as always. We hope that you will join us for our next Zoom. And if you know somebody that is interested in a virtual tour, or if one of you wants to catch up, we're able to start doing some touring now, and people have started moving back in this last month or so. So things are looking better here at the Lakeshore. And so we're excited about that and ready to welcome you with open arms. So with that, again, thank you, Abby, and for all our participants, thank you so much for being here today. We love it. And we look forward to seeing you very, very soon. Have a great day, everybody.
Thanks again, everyone. Take care.
Bye-bye.